Okay, we'll move on to the next part of our program and stay on time. I'm Dave Kindig from the University of Wisconsin and co-chair of the roundtable with my colleague George Isham, who you saw earlier. It's my pleasure to moderate this next panel, sort of actually picking up on some of Paula's last slides about research into practice. This is a panel on research in practice, opportunities and challenges. I was thinking about that walking over this morning, and some of you may know that in many, if not all, of the IOM reports that you've ever seen, including our workshop summaries, of which there's plenty out there, there's a little quote on the very front page with the IOM logo. It's from Goethe. It says, "Knowing is not enough, we must apply. Willing is not enough, we must do." So that's the imprimatur on every IOM publication that comes out, and that sort of sets the tone for this. I also was going to say that George mentioned that we were really fortunate to help sponsor yesterday's inaugural meeting of the new Association for Interdisciplinary Population Health Scientists, some of whom are joining us here today. And actually, it was an exciting day, and it's an important event for our field, for that organization to get kicked off and started. In their vision statement of that association, which you wouldn't have read certainly, they not only talk about the two goals of producing high-impact, cutting-edge, multidisciplinary population health science, but also the association will develop activities and partnerships that foster the exchange of knowledge between population health scientists and the end users of science in the world of policy and practice, and help build effective communication platforms and best practices for knowledge dissemination in order to facilitate the translation of research in the service of improving population health and eliminating disparities. So that's the spirit in which this panel is organized, and we'll speak. So we have four great panelists. Their full bios are in your materials, so I won't go over them in detail. They'll each speak for 10 minutes. First will be Maya Brennan, who's Vice President for Housing at the Urban Land Institute and the Terwilliger Center for Housing. Then second, David Holtgrave, Professor and Chair of the Department of Health, Behavior, and Society at Johns Hopkins Bloomberg School of Health. Then third, Brendan Nyan, Assistant Professor in the Department of Government at Dartmouth College. And then finally, Lisa Simpson, who's President and CEO of Academies Health, a major research and dissemination organization, and a member of the planning committee. So with no further ado, I'm going to turn it over to Maya.
Thank you very much, David. Let me get to the front of these. There you go. So my role here is to talk a bit about population health from the housing standpoint. One of the things that we do at the Urban Land Institute Terwilliger Center for Housing is operate a website, which is funded by the John D. and Catherine T. MacArthur Foundation primarily, called How Housing Matters. And the goal of this site is precisely to take all of the research that we already have, the $25 million that the MacArthur Foundation has put into understanding the importance of housing for health, for education, for economic well-being, and find ways to get that applied, to get more people talking about the research, to get more people understanding what they can actually do with this research. So we've already kind of, I feel like a lot of the groundwork has been laid through the great presentations earlier today. Where you live really matters. Where you live really matters for your health opportunities. It matters for a lot of other drivers of health. And ultimately, it all comes down to housing affordability. If you don't have an affordable option of a place to live that's the right size for your family, that's near enough to your work, you are unable to pay for food, you're unable to pay for medication. Also, indirectly, housing affordability impacts things like stability. If you can't afford to reliably pay your rent, you're likely to be evicted. If you cannot afford the down payment for a home, you are likely to just have have your lease not be necessarily renewed, and you won't be able to stay, and all of that goes further along to impact health. Housing affordability also directly influences things like the quality of the home in which you live, whether you have lead paint or not, whether you have pest infestations or not, whether you have other aspects of quality in the broader location that allow you to in turn thrive. If it were not for building codes that bring housing quality up to a good standard, people would be able to live somewhere. It wouldn't be a healthy place to live. So we need to find the right balance here in getting all of this ultimately to work. Housing affordability also, influences a variety of things about the neighborhoods in which we live. For very many families in the U.S., it's impossible to afford a home in the type of low crime, high opportunity neighborhood that they would want. So when we think about the ways that housing and health relate, I'd also suggest that in addition to these particular pathways that I've shown here, housing has an opportunity to act as a portal. And we think about housing as a platform in these ways, where housing affordability allows all of these other things to happen. But in this portal sense that it can be as well, a multifamily development or a clustered housing development also allows opportunities for public health practitioners to be able to come in and provide information and resources in a way that's much more accessible for vulnerable populations. So there's a lot of work going on in these kind of practical partnerships that's less around the research and just around opportunities, as well as the research base that we have through the site. I'm going to briefly walk you through 3 examples, and there's a wealth of research on the site. I encourage you to dig in, also to send information in that you would like us to help disseminate. But I'm going to briefly walk you through 3 examples of research and practice. The one that you see here I think of as sort of a best case. Another is a promising case, and another is more of a warning. So in the best case scenario, many of you are probably familiar with the Culhane report. In 2002, Dennis Culhane, Stephen Mitreau, and Hadley wrote quite influential piece that was in housing policy debate, saying that public service costs from a variety of agencies in New York City were lower when you put folks into supportive housing, and that it actually fully covers the cost of putting them into supportive housing. This has led to massive changes in the way that we think about and in the research around ending chronic homelessness. It has spurred further research in a variety of localities about housing first applications, where you don't force a homeless person to be on their medication, you don't force them to be off drugs or alcohol, you just provide them with shelter as that base through which they can access all sorts of other services that allow them to thrive. This research on its own, so it's not the most dense of academic articles that I've read, but it's dense enough to think it's not going to make headway with a policymaker unless you figure out how to translate and communicate this out. There's a tremendously popular article from Malcolm Gladwell in the New Yorker around this idea that this one particular homeless gentleman in New York, Murray, cost $1 million to the city through all of his in and out of the hospital and other services. This research is part of us actually making headway towards ending chronic homelessness. It's also part of us ending veteran homelessness. There are still certainly cases coming through. We still have far too many homeless people, but this research has been quite influential in practice, in part because it has this cost-saving element to it, which really gets the policymaker's ear, and through the popularization. Now, in the promising realm, the Moving to Opportunity demonstration from the 90s took 5 different cities and public housing residents in 5 different cities and said, we know through a variety of research that the neighborhoods in which low-income families live are neighborhoods in which the health outcomes are not great, the education outcomes are not great, a variety of things are going on in these neighborhoods. It took that bit of research and took a legal settlement in the Chicago area, the Gautreaux case, in which families, through a racial discrimination suit against the city, a set of families were given specific vouchers to be able to move from a majority minority area to be able to move to a majority white area. MTO changed it and said, we're going to not do it around race, we're going to do it around poverty. So they had to move to a low poverty area. What they ended up finding in tracking the health outcomes and other outcomes were moving to an opportunity neighborhood, meaning a low poverty neighborhood, 10 to 15 years later was the equivalent for diabetes reductions of other specific diabetes treatments. An estimated 34% reduction in new cases of diabetes from the families that actually moved. There were also substantial significant effects around obesity. Families that moved were less likely to have physical limitations in their ability to get around their residences later, less psychological distress, less lifetime depression. So there were a variety of quite positive and striking results from this. However, this study, because of the nature of racism in the society, this study struck upon two different limiters. One is that white flight was white flight for a reason. The families that left have still continued to pass on this fear of the other being in their neighborhood. And so there's a lot of NIMBYism, and the NIMBYism, not in my backyard syndrome, led in particular in Baltimore to families in neighborhoods that would not even have been eligible to move, crying out that they didn't want those people coming here. And the demonstration was never shifted from being a demonstration into a full program. So it ended after the initial demonstration period. There's also a backlash from within communities of color to some degree as well, because relocation sparks ideas of urban renewal and your homes and your communities being torn apart and not valued. And so there are these two striking forces that may limit us from actually seeing the potential of this study to both help understand how we can improve as a society neighborhoods of lower health opportunities, and how we can improve choices and opportunities to move elsewhere. However, it has substantially influenced the policy debate. There continue to be federal policies and programs that are addressing the desire to help families move to choice neighborhoods. We haven't gotten quite as much around how do we actually create and instill policies that help to revitalize neighborhoods in which these high poverty communities actually reside within. So I would put this in the promising category. We've learned a lot. We know that there are a lot of policy dialogues that are building off of this research base, but we haven't quite figured out yet whether we can get beyond the sense among a lot of policy folks that low-income communities can't necessarily be revitalized and you have to move people out, or the sense from the suburbanites that we don't want our suburban community's character to be changed. Now, my warning case sort of builds off of these fears. The idea of health impact assessments is quite striking and profound. There's a health impact assessment of the rental assistance demonstration, which really could have used a bit of a research and policy perspective at the start. They analyzed the program, which was a way to be able to actually improve quality of public housing, since we have no political will to actually reinvest in it. There's a huge backlog of capital needs. Families are living in quite terrible housing that the federal government is paying for, but not paying adequately for its repair. There are proven approaches to be able to actually change that. Infusing federal tax benefits plus private funding to be able to get the money despite Congress's inability to actually fund public housing. And this health impact assessment analyzed it as if it were a relocation program instead of a quality improvement program, despite the fact that families would have been able to stay there. As a result, we have quite a lot of newspaper articles around the RAD program suggesting that it would privatize public housing in a way that will create instability there, and that and it has led to HUD needing to constantly reinforce its message that this is not what this program is. All of the pages on HUD about it have a lot of myth busting. So it encourages us to think in this setting about how not framing the research question correctly and framing it from this mistaken standpoint can actually potentially harm policy outcomes in the end.